Thanks, Rob. I'm going to briefly touch on a couple of the advances surgically in the management of Blount's disease, but before we do that, we'll talk a little bit about the advances in our understanding of the etiology as well as the radiographic evaluation. Blount's disease, as everybody in the room knows, is a developmental disorder of growth affecting the medial aspect of the proximal tibial physis, resulting in progressive tibia vera. And it's broadly classified into two groups, infantile and adolescent, and that's basically done by age. You can see on the left an infantile Blount's bilateral disease. On the right, a girl with adolescent Blount's unilateral disease involvement. Our understanding of the etiology is that it's basically on a mechanical basis. Abnormal compression in the medial aspect of the proximal tibial physis results in growth retardation. And there's certain common observations that many people have made, including the fact that these kids tend to walk earlier, they tend to be obese, there's significant racial variation, and our understanding has been broadened greatly by some of the finite element analysis that Steve Burke and others did about 20 years ago. I want to refer to that article first by Steve Cook and Steve Burke and others. And basically, they made several observations. They observed that weight bearing was a prerequisite for Blount's disease, that it required at least a year of ambulation to express the disease fully. And it's usually diagnosed after 2 years of age. And they found that early osteotomy was curative. They were aware of things such as the Hutter-Volkmann law, which said that increased pressure on the physis medially inhibits growth, and release of that abnormal pressure results in growth stimulation. And they were also aware of the fact that stress of about 4.1 millipascals, or 600 pounds per square inch, is necessary to shut down the growth of the physis entirely. And based on their analysis, they found that a normal 2-year-old with varus of greater than 20 degrees tends to result in progressive varus deformity. A normal 5-year-old with 10 degrees of varus is borderline whether they're going to have a progressive deformity. But an obese 5-year-old with greater than 10 degrees of varus tends to be a progressive problem. And these numbers seem to have stood the test of time clinically in terms of other people's observations since then. This was all done about 20 years ago. Since then, the more important observations that have been made regarding Blount's disease have been really mechanical axis planning and evaluation, and also how we evaluate these patients in terms of radiographs. And a lot of that work was actually done by our prior speaker, Dr. Paley. And I'll refer you to a couple of articles as we go through that. Basically, one of the most important observations in the treatment and management of Blount's disease is that long leg x-rays are essential. You can't evaluate your mechanical axis without it. Here's a case on the left of a girl who had bilateral infantile Blount's surgically corrected 3 times before she presented here. We had all of her prior x-rays. She never had a long leg film, so at each one of her surgical procedures, there was never an evaluation of her mechanical axis, and she, of course, had a predictable recurrence after each of her deformity correction surgeries. I'd just make a reference to Dr. Paley's article in 1992, which was really the first time that I came to appreciate the importance of mechanical axis planning in Blount's disease. And it's subsequently been referred to in multiple different publications of his, including his most recent textbook. But I think that that's really an integral and most important reference for anybody who's going to address these sort of clinical problems. It's important to evaluate the kids with stress x-rays, assess them for ligamentous instability. That's going to affect your operative approach. And don't forget that this deformity is not just a frontal plane deformity. It's an oblique plane deformity. You need a lateral x-ray in order to evaluate their deformity truly. And if you're going to correct it, you have to be aware of the deformity. So lateral x-rays are obviously an integral part of it. For me, every kid before we do surgery gets an MRI, and that's really to rule out a medial physeal growth arrest. You may not be aware of it on plain x-rays, and I think it's important to get that preoperatively. You may be surprised by a recurrent deformity after your surgery. So I'm going to briefly touch on some of the advances in the last 20 years in the management of Blount's disease. Obviously, we're not going to talk about all of them, and we're going to get to the actual osteotomies in a minute. There are a couple of specialty procedures that I think deserve some mention. Intra-articular osteotomy among them. The indications for intra-articular osteotomy in the setting of Blount's disease, at least as espoused by the people who've written about it, is severe or excess ligamentous laxity, extreme sloping of the medial proximal tibial condyle, and these procedures are usually associated with premature medial epiphyseal plate closure. Langenskold and Riska described this procedure in their landmark article in 1964, and since then a number of different authors, including Perry Schenecker, have written about it. This osteotomy is done through an anteromedial approach to the tibia. The osteotomy bisects the intercondylar tibial eminence, and an arthrotomy is usually described in order to visualize the articular surface. You may also require metaphyseal osteotomy simultaneously in order to get appropriate mechanical axis alignment after the intra-articular osteotomy is completed. And these are Dr. Schenecker's photographs from his article demonstrating this technique. Dr. Paley's written about this as well in his textbook, and the location of the osteotomy is really determined by the laxity of the knee ligaments, whether it's proximal or distal to the medial collateral insertion. There's some controversy surrounding the use of intra-articular osteotomies, and the Stanitskys have written about this, and they did a study looking at MRIs and arthrograms, and they questioned the concept of routine joint elevation, as in many of these patients there did not appear to be a true empty space when they evaluated them with arthrogram or with MRI. Yet this still is described as a very valuable adjunctive procedure in certain cases. Asymmetric physeal distraction has been described in small series, and it has really a limited application, but I mention this as one of the advances because I think it's been well described recently. The indications for this procedure are adolescents with tibia vera who are very close to skeletal maturity. The advantages to this procedure is that there's no incision on the tibia, there's no fibula osteotomy. The actual deformity correction is at the site of the deformity, at the physis, and you can, as described, the authors disrupt actual bony bridges with this as well, and you can do lengthening simultaneously. And these are some photographs just shown from the article from 1997 describing this. One of the hypothetical complications of this procedure is the proximal pins can be intra-articular, and that's something that would be of some concern potentially. So where are we going and where have we been in terms of osteotomies in the treatment of Blount's disease? In the 1980s and 1990s, internal fixation was really the gold standard for correction of deformity. And that's well described in multiple articles. There's an article in the early 90s by Steve Burke and some other HSS alumni. Another article by Mike Millis out of Boston later in the 90s describing an oblique osteotomy and internal fixation. And there's some significant advantages to internal fixation as opposed to the pins and plaster we saw in the earlier x-ray, in that you can do very accurate correction. You can pre-bend your plate. You can measure your deformity correction beforehand. You get immediate correction in the operating room. It's very stable fixation, and you don't need a cast afterwards. But there are some disadvantages, and the disadvantages of internal fixation include the fact that the osteotomy tends to be a little bit more distal from your site of your actual deformity. You can't translate the distal fragment at all. There's really no room for error in your deformity planning. You either get it right or you're off, and it does require a relatively large dissection. Some of the developments post mid-1990s and things that have been used around the world even from before that include external fixation. Monolateral external fixation is well described. Dr. Price has written several articles on it, and multiple other people have used this as well successfully. The advantage of monolateral external fixation in the management of Blount's is that it's very simple. It's accurate. It's somewhat adjustable. And you can do either immediate or gradual correction of your deformity. Some of the disadvantages of monolateral frames are the fact that lengthening may be more difficult with this. It's much more difficult to do sagittal plane correction, and obviously rotational correction is more difficult or impossible with a monolateral frame. So that sort of leads to the evolution of the state of the art where I think we are now. which would be circular fixation. That includes the Elizaroff frame or the Taylor spatial frame, and this would be a representative case of a girl with adolescent Blounts previously operated on, who presents with and is treated with a circular frame with a percutaneous osteotomy of the tibia and fibula and complete correction of her mechanical axis gradually, approximately 30-degree deformity. And this is out of her frame. And there's another case of an adolescent boy, similar adolescent Blount's presentation, age 14 or 15, about a 25-degree deformity with a gradual correction. And this shows some of the advantages and disadvantages of circular frame fixation. Clearly, it's a very stable fixation. Difficult to do bilateral circular fixation in some of these kids with Blounts because clearing the affected limb can be difficult. So in terms of circular fixation, the advantages are that you can translate the distal fragment appropriately to realign your mechanical axis appropriately. You can place your hinges very precisely. You can locate your osteotomy more proximal or closer to the site of the actual deformity. Very stable frame, allows early weight bearing. You can fine-tune your mechanical axis and get it perfectly correct. You can also correct both length and rotation, and you can do that simultaneously. And you can do sagittal plane correction. Some of the disadvantages we just mentioned: soft tissue clearance can be difficult. Technically, the surgery can be a little bit, the application of the frame is more demanding than internal fixation. And post-operatively, obviously, requires a little bit of attention from the family. And finally, where are we in terms of the state-of-the-art? I'd say that the Taylor spatial frame is really the state-of-the-art in terms of circular fixation. It offers several distinct advantages over the traditional Elizaroff. This is a girl who had 3 prior surgeries in Nigeria. She had a 5-centimeter limb length discrepancy. She has internal rotation of her distal tibia of approximately 20 degrees and obviously recurrent Blounts, and underwent gradual correction with a Taylor spatial frame, which was just removed, I think, last week or 2 weeks ago. But clearly a case like that demonstrates the advantages of the Taylor spatial frame. You can correct every plane of deformity simultaneously. You don't need to stage it. You can correct coronal, sagittal, length, and rotation all at the same time. It's not an easy Elizaroff. It requires the same attention to detail and preoperative planning, but allows very precise correction. So in summary, the advances in the operative management of Blount's disease are not all operative or technical. I think that some of the major advantages, the major advances are better understanding of the mechanical etiology, and probably the most important thing is understanding of appropriate mechanical axis planning and assessment of the deformity. Thanks.